ಅಂಧಕಾರವ ಓಡಿಸು, ಜ್ಞಾನ ಜ್ಯೋತಿಯ ಬೆಳಗಿಸು.
ಹೃದಯ ಮಂದಿರದಲ್ಲಿ ನೆಲೆಸು, ಚಿಂತೆಯಾಳಿಸು.
ಹೃದಯ ಮಂದಿರದಲ್ಲಿ ನೆಲೆಸು, ಚಿಂತೆಯಾಳಿಸು.
ಶಾಂತಿಯ ಉಳಿಸು,
ಶಾಂತಿಯ ಉಳಿಸು.
ತಾಯಿ ಶಾರದೆ ಲೋಕ ಪೂಜಿತೆ,
ಜ್ಞಾನದಾತೆ ನಮೋಸ್ತುತೆ.
ನಿನ್ನ ಮಡಿಲಿನ ಮಕ್ಕಳಮ್ಮ, ನಿನ್ನ ನಂಬಿದ ಕಂದರಮ್ಮ.
ನಿನ್ನ ಮಡಿಲಿನ ಮಕ್ಕಳಮ್ಮ, ನಿನ್ನ ನಂಬಿದ ಕಂದರಮ್ಮ.
ನಿನ್ನ ಕರುಣೆಯ ಬೆಳಕಲೆಮ್ಮ, ಬಾಳನು ಬೆಳಗಮ್ಮ.
ನಿನ್ನ ಕರುಣೆಯ ಬೆಳಕಲಮ್ಮ, ಬಾಳನು ಬೆಳಗಮ್ಮ.
ನಮ್ಮ ಕೋರಿಕೆ ಆಲಿಸಮ್ಮ,
ನಮ್ಮ ಕೋರಿಕೆ ಆಲಿಸಮ್ಮ.
ತಾಯಿ ಶಾರದೆ ಲೋಕ ಪೂಜಿತೆ,
ಜ್ಞಾನದಾತೆ ನಮೋಸ್ತುತೆ.
ಒಳ್ಳೆ ಮಾತುಗಳಾಡಿಸು, ಒಳ್ಳೆ ಕೆಲಸವ ಮಾಡಿಸು.
ಒಳ್ಳೆ ಮಾತುಗಳಾಡಿಸು, ಒಳ್ಳೆ ಕೆಲಸವ ಮಾಡಿಸು.
ಒಳ್ಳೆ ದಾರಿಯಲೆಮ್ಮ ನಡೆಸು, ವಿದ್ಯೆಯ ಕಲಿಸು.
ಒಳ್ಳೆ ದಾರಿಯಲೆಮ್ಮ ನಡೆಸು, ವಿದ್ಯೆಯ ಕಲಿಸು.
ಆಸೆ ಪೂರೈಸು,
ಆಸೆ ಪೂರೈಸು.
ತಾಯಿ ಶಾರದೆ ಲೋಕ ಪೂಜಿತೆ,
ಜ್ಞಾನದಾತೆ ನಮೋಸ್ತುತೆ.
ಪ್ರೇಮದಿಂದಲೇ ಸಲಹು ಮಾತೆ, ನೀಡು ಸನ್ಮತಿ ಸೌಖ್ಯದಾತೆ. ತಾಯಿ ಶಾರದೆ ಲೋಕ ಪೂಜಿತೆ,
ಜ್ಞಾನದಾತೆ ನಮೋಸ್ತುತೆ. ಜ್ಞಾನದಾತೆ नमोस्तुते।
देश के लिए कुछ करना चाहूँ सर। हमारी भारत माता है ना जो
ನೀನಾಡೋ ಮಾತೆಲ್ಲ ಚೇನಿನಂತೆ ನಗುವಾಗ ನಿನ ಮಗವು ಹೂವಿನಂತೆ ನೀನೊಂದು ಸಕ್ಕರೆಯ ಗೊಂಬೆಯಂತೆ ಮಗುವೇ ನೀ ನನ್ನ ಪ್ರಾಣದಂತೆ, ಚಿನ್ನ ಪ್ರಾಣದಂತೆ. ಆನದಾರಿಯಲ್ಲಿ ಸೂರ್ಯ ಜಾರಿ ಹೋದ, ಚಂದ್ರ ಮೇಲೆ ಬಂದ, ಮಿಣಗುತ್ತಾರೆ ಅಂದ, ನೋಡು ಎಂತ ಚಂದ. ರಾತ್ರಿ ಆಯ್ತು ಮಲಗು ನನ್ನ ಪುಟ್ಟ ಕಂದ, ನನ್ನ ಪುಟ್ಟ ಕಂದ. ರಾತ್ರಿ ಆಯ್ತು ಮಲಗು ನನ್ನ ಪುಟ್ಟ ಕಂದ, ನನ್ನ ಪುಟ್ಟ ಕಂದ. ರಾತ್ರಿ ಆಯ್ತು ಮಲಗು ನನ್ನ ಪುಟ್ಟ ಕಂದ, ನನ್ನ ಪುಟ್ಟ ಕಂದ. ನಿನ್ನ ಕಂಗಳ ಬಿಸಿಯ ಹನಿಗಳು ನೂರು ಕಥೆಯ ಹೇಳಿವೆ, ನಿನ್ನ ಪ್ರೇಮದ ನುಡಿಯ ಕೇಳಿ ನೂರು ನೆನಪು ಮೂಡಿವೆ. ನಿನ್ನ ಕಂಗಳ ಬಿಸಿಯ ಹನಿಗಳು ನೂರು ಕಥೆಯ ಹೇಳಿವೆ, ನಿನ್ನ ಪ್ರೇಮದ ನುಡಿಯ
We'll tell you if you're born to flow.
ನಿನ್ನ ಕಂಗಳ ಬಿಸಿಯ ಹನಿಗಳು ನೂರು ಕಥೆಯ ಹೇಳಿವೆ, ನಿನ್ನ ಪ್ರೇಮದ ನುಡಿಯ ಕೇಳಿ ನೂರು ನೆನಪು ಮೂಡಿವೆ. ನಿನ್ನ ಕಂಗಳ ಬಿಸಿಯ ಹನಿಗಳು ನೂರು ಕಥೆಯ ಹೇಳಿವೆ, ನಿನ್ನ ಪ್ರೇಮದ ನುಡಿಯ ಕೇಳಿ ನೂರು ನೆನಪು ಮೂಡಿವೆ. ತಂದೆಯಾಗಿ ತಾಯಿಯಾಗಿ ಮಮತೆಯಿಂದ ಬೆಳೆಸಿದೆ, ಬಿಸಿಲು ಮಳೆಗೆ ನರಳದಂತೆ ನಿನ್ನ ನೆರಳಲಿ ಸಲಹಿದೆ. ಆ ಪ್ರೀತಿಯ ಮನ ಮರೆವುದೇ, ನಿನ್ನ ಕಂಗಳ ಬಿಸಿಯ ಹನಿಗಳು ನೂರು ಕಥೆಯ ಹೇಳಿವೆ, ನಿನ್ನ ಪ್ರೇಮದ ನುಡಿಯ ಕೇಳಿ ನೂರು ನೆನಪು ಮೂಡಿವೆ. ನಿನ್ನದೇ ನೆನಪು ದಿನವೂ ಮನದಲ್ಲಿ, ನೋಡುವ ಆಸೆಯು ತುಂಬಿದೆ ನನ್ನಲ್ಲಿ ನನ್ನಲ್ಲಿ. ನಿನ್ನದೇ ನೆನಪು ದಿನವೂ ಮನದಲ್ಲಿ, ನೋಡುವ ಆಸೆಯು ತುಂಬಿದೆ ನನ್ನಲ್ಲಿ ನನ್ನಲ್ಲಿ. ತಂಗಾಳಿಯಲ್ಲಿ ಬೆಂದೆ ಏಕಾಂತದಲ್ಲಿ ನಾನೊಂದೆ, ತಂಗಾಳಿಯಲ್ಲಿ ಬೆಂದೆ ಏಕಾಂತದಲ್ಲಿ ನಾನೊಂದೆ. ಹಗಲಲ್ಲಿ ತಿರುಗಿ ಬಳಲಿದೆ, ಇರುಳಲಿ ಬಯಸಿ ಕೊರಗಿದೆ, ದಿನವೂ ನಿನ್ನ ನಾ ಕಾಣದೆ. ನಿನ್ನದೇ ನೆನಪು ದಿನವೂ ಮನದಲ್ಲಿ, ನೋಡುವ ಆಸೆಯು ತುಂಬಿದೆ ನನ್ನಲ್ಲಿ ನನ್ನಲ್ಲಿ. ಕಡಲಿಂದ ಬೇರೆಯಾಗಿ ತೇಲಾಡು ಮೋಡವಾಗಿ, ಕಡಲಿಂದ ಬೇರೆಯಾಗಿ ತೇಲಾಡು ಮೋಡವಾಗಿ, ಕರಗುತ್ತ ಹೊರಗೆ ಇಳಿಯುವುದು, ಹನಿಯುತ ಕಡಲ ಬೆರೆವುದು, ನಮ್ಮಿ ಬಾಳಿನ ಬಗೆಯಿದು. ನಿಮ್ಮದೇ ನೆನಪು ದಿನವೂ ಮನದಲ್ಲಿ, ನೋಡುವ ಆಸೆಯು ತುಂಬಿದೆ ನನ್ನಲ್ಲಿ ನನ್ನಲ್ಲಿ.
ಪಟ್ಟು ತೀರಿಸಿಕೊಳ್ಳೋಣ.
ಇದು ಫ್ರೆಂಡ್ಲಿ ಮ್ಯಾಚ್ ಮಾಹಿ.
ನಾನು ಯಾರ ಮಾಹಿವಾಹಿನೂ ಅಲ್ಲ, ಇದು ನನ್ನ ಖಡ್ಗ.
ಮತ್ತೆ ಇದು ಬೆಂಕಿಯ ಚೆಂಡು.
ಯಾರು ಹೇಳಿದ್ದು?
ಮಾಹಿ, ನೀನ್ ಸ್ನಿಕರ್ಸ್ ತಿನ್ನು.
ಯಾಕೆ?
ಯಾಕೆಂದ್ರೆ ಹಸಿವಾದಾಗ ಇವನ್ ಕ್ಯಾಪ್ಟನ್ ಕೂಲ್ ಲೂಸಸ್ ಇಸ್ ಕೂಲ್. ಈಗ ಸರಿನಾ?
ಸರಿ.
ಹಸಿವಾದ್ರೆ ನೀನಾಗಿರಲ್ಲ. ಹಂಗ್ರಿ ಎತ್ಕೊಳ್ಳಿ ಸ್ನಿಕರ್ಸ್.
ಅಲಿದಾಡು ಮನಕ್ಕೆ ಸೊಗಸಾದ ಸಾಲು ಸಂಪಿಗೆ ವಾರು ನನ್ನನು ನೋಡಿ ಮುಂಜಾನೆ ಮಂಜು ಹಸಿ ವಿಶ್ವಾಸ ಮೇಲ್ ನೋಡು ಸರ್.
ಗುಡ್ ಮಾರ್ನಿಂಗ್ ಫ್ರೆಂಡ್ಸ್, ವೆಲ್ಕಮ್ ಟು ಕಲ್ಪತರು ನಾಡು ತುಮಕೂರು. ಜ್ಞಾನದಾಸೋಹ ಹಾಗೂ ಅನ್ನದಾಸೋಹದ ನಾಡಿಗೆ ಸ್ವಾಗತ, ಸುಸ್ವಾಗತ. ಇಂದಿನ ಮುಂಜಾನೆ ನಮ್ಮೆಲ್ಲರಿಗೂ ಶುಭದಾಯಕವಾಗಿರಲೆಂದು ಗಣೇಶನ ಪ್ರಾರ್ಥಿಸುತ್ತಾ ಇಂದಿನ ಕಾರ್ಯಕ್ರಮವನ್ನು ಪ್ರಾರಂಭಿಸುತ್ತಿದ್ದೇವೆ. ಇಂದಿನ ಟುಡೇ ಸೆಷನ್ ವಿಲ್ ಸ್ಟಾರ್ಟ್ ವಿತ್ ಅಖಿಲಪುರಶ್ರೀ ಸೆಷನ್. ಐ ರಿಕ್ವೆಸ್ಟ್ ಡಾಕ್ಟರ್ ಮುನೀಶ್ವರ್ GB and Dr. Vishwanath sir to be on the dais as a moderator. I request Dr. Subramania sir to start his session, DCR with stent. So we'll connect from eye to nose. Dr. Subramania sir.
Thank you, Dr. Manjunath, for giving me an opportunity to present over here. So, topic which we have selected is binocular lacrimal stent and DCR. So, we do a lot of DCR cases regularly. So, sometimes even with a good surgical outcome also, we won't get a better anastomosis. Like patient still might have the watering even after the good surgery also. So that's called failed DCR. And also sometime with the canalicular obstruction and all, we'll have to go for a bicanalicular lacrimal stent. That is what I am focusing at here. Coming to the small anatomy, you know where the punctum starts and the canalicular, common canalicular, and then goes to the lacrimal sac and then NLD. So physiology, the tears are secreted in the lacrimal gland, we know that, and pass through the lateral across the ocular surface to the lower canaliculi, and finally it passed to the lacrimal sac and NLD. And we know that NLD opens in the anterior part of the outer wall of inferior meatus, and this opening is guarded by walls of Hasner. So there are so many diseases can happen in the lacrimal pathway, starting from dacrystitis. That's where we are going to concentrate. And we know the CNLDO, punctular canalicular obstruction, some other disease also. So evaluation, I'm not going to detail. I'll just read up. Examination of the outer part of the eye is very important, and we have some tests like a regurgitation test and lacrimal sac syringing and fluorescent dye disappearance test and Jones eye test. We do regularly all this evaluation before going for the surgery. And treatment option, if acute, we know what to do, and then with a chronic, we know DCR or DCR with stent. These are the options we have. So the topic which I am focusing is the DCR with the bicanalical stent. External DCR is effective surgical treatment for all NLD obstruction, but even though it yields about 90% success rate, but some patient might have epiphora. So bicanalical stent is widely used in this method for both. We do it in both in external and endonasal also. History of the stent is important. The various types of material we have used as a stent for the stenos punctum or even with the dacrystitis also. It was introduced in 1932, and since then various materials have come which are used and which was revolved also. So ideal stent should be inert, pliable. It has smooth external surface. It should be self-retaining, and it should be cheap, affordable, easily available, and simple to use, and should not cause any mechanical damage to the surrounding structure. So the main condition we use is the canalicular stenosis and also trauma, canalicular laceration, and also some case of CNLDO, and mainly for the revision DCR. What are the types we use? Monocanalicular and bicanalicular. The mainly I'm concentrating on bicanalicular stent. So we know that monocanalicular stent can be used for the canalicular obstruction also. Sometimes the canalicular laceration, the most commonly is mini monoca TM stent, and bicanalicular stent we use mostly the self-retaining bicanalicular stent, and also that operants. So we know the DCR step starting from the nasal packing and anesthesia, and then we give the J-shape incision or some vertical incision, especially 3 mm from the medial canthus, and we need to expose the MPL and anterior lacrimal crest, then expose the bone, make a ostium in the bone, and then we take a nasal flap and lacrimal flap, and then we suture the flap. So there are causes for the failed DCR, like inadequate rhinostomy or unrecognized canalicular obstruction, or excessive scar tissue production, anatomical anomalies, septal deviation, something called SUM syndrome, where the lacrimal bone opening is too small or the high too high, so it does acts like a sump rather than the anastomosis. So these are the indication. The mechanism, it acts as a function like a tear which flows along the surface of the stent, and also sometimes the stent will itself help to the dilate the lumen of the punctum and also lumen of the canaliculae, so that the flow will be better. So like I have done many like a bicanal stent. I have gone through all the techniques. This is just my experience which I am sharing. So first technique which I have done is, after doing the normal DCR, so I have passed the stent through the punctum and then canaliculae. And what I did is the metallic part of the stent which is retrieved directly through the nose. So that was the animational video. This is a surgical video. You can see that the stent is passed through the punctum and then this is in a sac, and it is directly retrieved from the nose. This was the easiest technique. Only thing is where the you have to be careful, because you are introducing the instrument through the nose. So sometime it can cause some problem while doing surgery also. So next what I tried is, okay. Then the next what I tried is, after introducing the, it's not, So what I tried is, after introducing the this thing metallic part of the stent, I have cut the metallic part. I have left it only the silicon tube, and then I have retrieved the silicon tube through the nose. So pulling out the metallic part, sometime you can cause trauma to the nasal mucosa. So while pulling out the silicon tube, it is very easy. So this was type of technique which I have retrieved the metallic part of the stent, and then I have cut the metallic part. Then I have retrieved the only silicon tube through the nose. Again, here you have to introduce the forceps or the Chili's forceps through the nasal mucosa. So again, there is a on table. Sometime a patient can have some kind of. You can see. Only thing is you don't have to pull the metallic part, because that sometime it can cause trauma to the nasal mucosa. And third, what I have done is I have cut the metallic part of the stent, and then I have pulled out the nasal gauze piece, and I have made a hole in the gauze, and then I have made a small knot in the gauze, and then I have pulled out the gauze instead of putting any instrument to the nose. So here what I have done is I have retrieved the metallic part of the stent to the lacrimal sac area, and then then I have cut the metallic part, and then I have made a hole in the gauze piece, gauze nasal gauze, and then I had made a small knot, and then pulled out the one nasal gauze. This is the easiest technique compared to previous two technique, because you don't have to introduce any instrument through the nose. So then I thought, like, is it required to pull it out from the nose? Because anyway it will be sitting at the below your ostium. So why can't we once you retrieve the metallic part from the that sleeve from the this thing in to the wound, you can directly knot it and keep the knot inside the ostium instead of pulling it from the nose. So that is what I. Yeah, that is what I tried here. Like I remove the stunt from the this thing. I made a knot in there itself rather than pulling out through the nose, and then I put that loop into the below the ostium, and then I sutured the flap. So, yeah, this is second video. You make a knot, and then cut it and put that knot inside the ostium. So then you suture the flap instead of pulling it through the nose. So timing of the stent removal, usually 4 to 6 weeks after DCR surgery. This is because that by this period the osteum healing is complete, and if you kept it longer period of time, there may be a formation of granuloma. Usually in the canalicular obstruction, we remove it early, or remove it like a 3 to 4 months. If you are using it for the primary DCR surgery, you can remove by 6 weeks. So removal of the stent. This is the video where you don't have to send it to the ENT surgeon to remove the stent, where you can do it in a OPD procedure by itself. This was the patient who are around 6 year old. We have done a DCR surgery, and you can see that I have just pulled it out. You cut the sleeve part and pull it out. It will come very easily. The second video where you can see this is also around 7-year-old kid. We have done DCR, and you can see we are I am removing the stent in the OPD procedure only. You have to just cut the stent part, and then you have to just pull it out. It comes very easily. Only thing is, when you're putting the knot, you have to put only 2 or 3 knot. Don't try to put 5 or 6 knot, because then it will be very difficult to pull it out. It's a complication. We know the stent prolapse can happen, and also sometime when you're pulling it out, there may be a puncture slitting or cheese wiring also possible. Or sometime if you keep it for the longer period of time, that might cause a punctal or osteum granuloma formation, and sometime very rarely you can get a secondary bacterial infection. Thank you.
I requested Muneshu to comment on the pulling of the stent.
Good morning, all of you. We have been doing endonasal DCRs for quite long time. My numbers are very less, but according to the textbooks and literature, the results are almost equal. Endonasal DCR and external DCR both are almost at par. And in our textbooks and our articles, he gives more in favor of endonasal DCR only. He says it is less invasive, and you can monitor the opening, and you can maintain the lacrimal pump action. I think probably all the ophthalmologists will be aware of what is lacrimal pump action. He says it is better preserved in endonasal DCR, and we also use stents, and in fact one of the cases we use. But personally, I don't use most of the time stents. Or just you open the lacrimal sac, keep the lacrimal sac open, and monitor the nasal cavity by regular cleaning of the opening by endoscopes. Monitoring and regular syringing will keep the patency intact. And stent removal is not a big thing, so we can. Now we have, it's era of all endoscopes. We do everything using endoscope. Under vision, you can just put endoscope, and accurately you can cut the stent from inside. If the ophthalmologist has put the stent from outside, we can cut it and take out. And as Dr. Subramania has shown, he could also able to remove from outside. I think there is no problem. And anything else you want to discuss on endonasal DCR? There are very few steps. Actually, it can be done under local and as well as general anesthesia. There are very few steps. We just give local anesthesia and elevate the mucosal flaps, remove the bone, and you'll be on the right on the lacrimal sac. And you can just put a needle from outside, the lacrimal probe from outside to the canaliculus, and it will make a tenting action inside the nose. And exactly on the tent, you can just make a cut on the lacrimal medial wall of the lacrimal sac, and you can invert the margins of the lacrimal sac walls, anterior and posterior, and it is kept intact. I did not see any failures in my experience, actually speaking. Even in my beginning of my career, I never saw any care. Initially, there was a learning curve, of course, and once you learn it, I think there should not be any problem in doing endonasal DCRs. I think one can go with confidently with endonasal DCRs.
Any bleeding?
Sir, like any surgery, bleeding is a complication, but it is not that bad. It is easily manageable. There is no problem in managing bleeding. Absolutely no problem. It is.
How many of you in the audience are doing DCR? Like they are come across with the failed DCR? Anybody has done stent before? I mean, anybody in the audience who have done stent, like bicanal stent for the DCR? Okay, actually, the doing especially in a failed DCR where we really don't know what will happen inside the ostium. The many times there will be a lot of granulation. I mean, if you open the failed DCR cases, revision DCR cases, there will be a lot of granuloma formation will happen. And sometimes we have felt like the DCR is done or not. Like it looks like a bone only. And how to use the chisel and then open it, and then again you will be confused that this patient had been undergone primary DCR or not. So much of granuloma formation will happen, and these cases are ideal cases for the stent. And doing the stent, yeah, initially it used to take little more time because you have to put through the punctum, and then you have to retrieve through the nose, because you will have won't have any anesthetist backup usually. I mean, you have, but no anesthetist may not be in the same OT. So we might feel like, okay, when you are pulling out through the nose, the patient might have this kind of problem, but usually no. Why? Because we have kept the nasal pack before removing the stent, so that nasal pack will have a lignocaine solution and all, so automatically it will give a lot of anesthetic effect, and you don't have to worry about that, and you can easily pull it out. And also you can sometimes you can cut it out and pull it uh, pass through the nasal pack also. That will be easiest method, and which I has shown the last technique, which you just make a knot and push it to the ostium, then you can do the flap. This was tried with many people also. We are getting a good result. Actually, I have done few cases. We usually getting a good result, and even the stenting also I have done quite a few, almost maybe around 50, 60 around bicanal stent I have done, and most of the case around 90 to 95% got a good success rate. And if some patient may be associated with lacrimal pump failure and all, we may not get a very good result, but most of the patients we have got a good result. Bleeding, as sir asked, yeah, definitely there will be a lot of bleeding will be there initial, like especially when you're doing a revision DCR. So that is a part and parcel how to do a good stenosis.
Thank you. Thanks for your comments, sir. So now I call upon Dr. Divya D. Sundaresh. Madam is going to speak on lid laceration repair, step-by-step approach. Dr. Divya, madam, please.
Tumkur Ophthalmic Society for giving me this opportunity to be here today and share a few thoughts on eyelid lacerations and a step-by-step repair. So for eyelid, the basics are extremely important, right? So we need to just brush up our anatomy each and every time we see a lid laceration, because we need to be sure as to identify the correct structures, and that's how we get a good repair. So the eyelid is a very complex structure. It contains many glands. It also contains the eyelashes. It also is divided into layers. For functional purposes is the anterior lamella and the posterior lamella. And the skin of the eyelid is also very important to assess. It's the thinnest skin in the entire body, and depending on the age, the tautness of the skin also varies, and this is also extremely important when it comes to eyelid repair. So the eyelid is divided into two halves, basically the anterior lamella and the posterior lamella, and separated by a fibrous kind of tissue called which forms the gray line. Now the anterior lamella consists of the skin and the orbicularis muscle, and the posterior lamella mainly consists of the meibomian glands, and the inner aspect is lined by the conjunctiva. Now when it comes to the lacrimal gland and the corners of the eyelid. These are extremely important as well in reconstruction. Now we have to understand that the eyelid function is also closely related to the pumping out of the tears as well. So assessment of the canaliculi and the medial canthus is also important when it comes to eyelid lacerations. When a person comes with a history of a lid tear, we need to realize that this is a medical legal case. So we also have to document it correctly. We need to ask detailed history, the nature of the injury, whether it was a blunt object, a sharp object, a road traffic accident, or someone punched them, or whether it was an animal bite. It really matters, because these documents are what is going to be, even if it may be simple or trivial to you, you never know, they'll come back later and say, we've now filed a case, now you need, some, it may not even be that they're going to get anything, but still the documentation is extremely important. Also, any past ocular history. Now, we may not have seen the patient before, we need not have his old vision records. So we need to collect all the past history as well, as to whether he had any intraocular procedures done, any other possible problems with his lid, because he might be amblyopic, and after the lid tear he might say that now I cannot see, you did something. So you need to make sure you ask for past history and check vision accurately. Also, when it comes to trauma, we need to assess about the tetanus vaccination state. Immunization is also important. And if it's an old person, any anticoagulants also needs to be checked. When it comes to examination, we need to rule out any life-threatening injuries first. Okay, life first, and then we go to the lids. Any globe injury next, and then we need to assess both the eyes. We need to make sure we haven't missed anything minor in the other eye. This may be gross looking, but in the other eye also there might be something we shouldn't have missed. And then, of course, documentation if possible with photos. And then plan for repair. Now, when we're assessing the eyelids, we need to assess there's margin involvement or not, whether it's full thickness or partial thickness involving the posterior and or anterior, the size of the defect, if there's any tissue loss, canalicular involvement, the location, medial, lateral or central, then canthal involvement, the levator function, if the patient is able to open on his own, any lag of thalamus, and any breach of septum where you might have a orbital fat prolapse. When it comes to eyelid trauma, you also need to assess how much of the lacrimal drainage system is involved. The age of the patient needs to be kept in mind, which will give you the laxity of skin. So you can undermine the skin and close it better. The condition of the opposite eyelid also you should know, and other eye, and mobility of the surrounding tissues. When will you do an imaging, especially if you suspect any retained foreign body, you suspect any fractures, facial fractures, you're unable to determine the posterior limit of the wound, you have to do a CT orbit. When should you repair? Generally, you should repair as soon as possible, within 24 hours, but you can delay when the patient is unstable, has gross swelling of the face. You can delay and suture at a secondary stage. Depending on the general status of the patient or the simplicity or complexity of the tear, it will be either general anesthesia or under local anesthesia. Now, first thing is you need to clean the wound, make sure you've removed any foreign debris, and minimal debridement. Every piece of tissue is extremely important, so don't be, feel that it's not going to be viable and cut it off, because facial skin is extremely vascular and it will heal beautifully. Careful handling of the tissue, and we need to close in layers. We need to always align the anatomy well with the lid margins, the lash line, and the skin, keeping in mind the lid margins, the lash line, and the skin fold. Now, when it comes to a very simple laceration, a very tiny laceration, hardly 1 mm, especially in a young child, even steri-strip will work if there's no tension across the laceration. Generally, otherwise we tend to use 6-0 Vicryl, or usually 6-0 Vicryl if it's away from the margin. Otherwise, if it's towards the margin, but if it's away from the margin, away closer, you can use Proline as well. When it comes to lamellar lacerations, you need to identify whether it involves the lid margin as well. You assess the depth of the tear, if there are any deep tissues involved, and especially in elderly age, if they have very lax skin, you can easily undermine the skin and suture them without any problem. When it comes to deep lacerations, you might have to identify if the septum is involved or not. You might have to identify if, so like in the lower picture, the canalicular involvement is there, but it was not very obvious at first look. And when you retract and see that there's a tear all the way extending in the depth of the orbit. So you need to identify the depth and posterior extent of the tear. Now, when it comes to suturing, we have simple concept of alignment, right? So basically we need to align the gray line to the gray line, lash line to the lash line, and the muscle to the muscle. So we start with the eyelid margin suture, where we do a horizontal mattress suture, and we take it through the tarsus in equal depth on both sides and align the gray line and the lash line. The subsequent suture we take to align the orbicularis muscle and close it. All right, we can leave the lash suture, we can leave it with a loose knot for the initial part, align the rest, and tighten it at a later stage as well. Once you tighten the orbicularis sutures and then the skin, and then you tighten the lash suture, lash line, gray line, and tarsal suture, you leave the length of the suture long and bury it in the skin suture so that it does not prick the cornea of the person. All right. So in this, we see that it's buried and there won't be any corneal abrasions. Now, when it comes to simple lid margin lacerations, we can do it under local anesthesia when we're sure. This was the case of a dog bite, and we can suture with local anesthesia. Now, when it comes to dog bite, we also have to ensure that patient gets the rabies vaccination. When it comes to canalicular lacerations, usually the upper canalicula is not really repaired. The lower one definitely needs to be repaired, otherwise they are watering for the rest of their lives. It needs to be done as early as possible because otherwise it's very difficult to identify the torn canaliculi opening. H0 Vicryl is used along the canaliculi, and for the skin and the margin, we can use 6-0 Vicryl. We also need to put a stent, either bicanacular or monocanacular, and leave it in for 3 months. Now here we see that initially we probe the canaliculi, identify the cut ends, and then pass the stent. And then after we pass the stent, we put the sutures, one above, one below, and then subsequently close the orbicularis and skin. Okay, sorry about that. The video is not playing. Now it comes to more complex lacerations. It looks complex, but actually not. You see that the lid is hanging. It appears like the lid is hanging, but it's not really so. When you assess again, you see that it's only a lamellar laceration and the margin is also hardly involved. So the goal is to provide adequate eye closure. We need to keep in mind that the approximation of the lid to the globe is well maintained, so that helps in the tear film. We need to also make sure that the the vision axis is unobstructed, and we need to have an aesthetically appealing eye. Complications of lid laceration repair can be lid margin notching, lag of ophthalmos because maybe there was severe loss of tissue and you cannot close it completely. There may be hypertrophy of the scars, infection. There can also be continuous tearing because there's the canalicula is not functioning really well, and you can also have a traumatic ptosis. Thank you.
Thanks, madam. Sir, Nagaraj sir. Any questions from the audience? Dr. Subramanian sir?
Yeah, it's good presentation. Like very basic question. Like suppose most of the lead tear patients, what we see in as a medical college, we usually they'll have a history of RTA and some kind of head injury and all, and there will be some amount of ecchymosis, lid edema along with the facial edema. So question is like, how do you manage? Like it's very basic. Like how do you manage with a patient who have come with RTA with a very bad lid injury? Usually, that is what we see in a medical college.
So, like I said, if there's a lot of facial swelling, we can wait. We can give them a cold compress head and elevation and wait for the swelling to subside along with anti-inflammatory. Now, generally, when they have a head injury, sometimes they also tend, the neurosurgery people also tend to start them on steroids that indirectly helps us as well. So, once the edema subsides, you can take it up after 2-3 days. They will still heal.
Will you directly suture or will you first put the primary suture and will you wait for the? There is a chance of infection also initially. How do you manage along with the infection?
Generally start them on IV antibiotics, and then if it's really bad that the tissue loss can happen, then you put just 2-3 stay sutures, and then we can freshen the wound later and take it up for complete repair.
Thanks, madam. Thanks for your inputs. Thanks for sharing the oculoplasty session. I request our TVS members to facilitate the speakers, Dr. Manjunath, Dr. Kaleshwar sir, and Dr. Pradeep. Sir, please. Dr. Subramania sir, please receive our thanks, gratitude from our TYS. Dr. Munishwar sir, from Dr. Kaleshwar. Dr. Divya madam, please receive token of gratitude from Dr. Pradeep. Thanks, friends. Thanks for attending our oculoplasty session. One common instruction for our audience: don't make noise. Please put your phones on vibrate mode or mute your phones. The hall is fitted with voice censored cameras. So if you make more noise, your photo will be displayed on the screen. So the speaker may not get his attention and the speaker may not concentrate on his talk. So our cameras are fitted with any random movements or positions or voice or the noise, it will be displayed on the screen and it disturbs the speakers. So please, now we will have cornea session. I request Dr. Harsha to be speaker.
The beginning of the cornea session. So I would like to call upon the stage our moderators for the cornea session, being Dr. T.K. Ramesh sir, Dr. G. Nagaraju sir, Dr. Rekha Gyanchand ma'am, Dr. M.S. Ravindra sir. And Dr. Harsha N. sir is going to talk on pterygium with OSSN, just masquerades or more. The session is going to be co-moderated by Dr. Shruti M.K., ocular pathologist from Narayan Nethralaya 1, and Dr. Nalini Yashwan ma'am, our own faculty pathologist from Tumkur. Please welcome you all on the stage, ma'am.
Good morning, everybody. At the outset, all of us from Bangalore would like to thank the Tumkur Ophthalmic Society for having us in this program. All the topics which are planned today are really exciting and scientifically thought-provoking also. We begin the cornea session with Dr. Harsha. He'll be speaking to us on pterygium with OSSN just masquerades and
Oh. Thank you, sir. So good morning, everyone. So at the outset, I would like to thank Tumkur Ophthalmic Association for giving us the opportunity to be here and be part of this wonderful CME. So I'll be talking about two of the most common lesions that we see in our day-to-day practice, the pterygium and OSSN. So classically, we have been taught that these two lesions have a very common etiology, they have a very common clinical presentation, but still the two are different. So in the next few minutes, we'll see if really they two are different or is there more to it than we actually know. We all know that Pingala changes to pterygium, right? And it's been classically defined as benign degenerative fibrovascular proliferation of conjunctiva. Whereas the spectrum of OSSN is described as neoplastic changes involving the squamous epithelium of conjunctiva, limbus, and cornea. So the differentiation here is one is benign, one is neoplastic. So the question for us here is the pterygium just stops at being a pterygium or does it progress on to being a OSSN? Right? That means is this pterygium just benign as it is stated or is it pre-malignant? Right? This is just a histopathological slide of pterygium. We'll be needing this as we go forward. Okay, so I'm just going to make it as simple as possible. You can see this epithelial layer here. This is quite, the uniform. There's no increase in the thickness or something. And the normal conjunctival epithelium is non-stratified, non-keratinized stratified squamous epithelium, meaning stratified meaning multiple layers. And there is no keratin here, right? So it's all uniform here. And the classic change what we see here is the actinic damage or elastotic degeneration. And there is loss of goblet cells. This is how we see in the pterygium. And this is about the OSSN. For us ophthalmologists, all this looks like colorful. For me also, it's the same thing, but I have a pathologist at home, so I have no option but to learn all this, right? So this is grade 1 or SIN 1, where this is the normal epithelium, and as it progresses, you can see that it's suddenly changing to abnormal epithelium here. Almost there's dysplastic cells here. These are the lymphocytes, right? When we have less than 1/3 of the dysplastic cells, it's called SIN 1. And similarly, when you have almost less than 2/3 involving dysplastic cells, this is the normal cells. So this is SIN 2. SIN 3 is the whole of the epithelium is involving the dysplastic cells. And when it penetrates through the basement membrane and gets into the substantia propria, we call it as squamous cell carcinoma. So remember that all the changes that we spoke about was in the epithelium. So why does this basically happen? So what happens here is in a normal conjunctiva, as I told you, it's non-keratinized stratified squamous epithelium. Whenever there's a insult, the most common type of insult what we see is UV radiation. This conjunctiva gets converted to hyperplasia. Hyperplasia is a compensatory mechanism. So where the cells become more in number, but still their polarity is maintained, and even the nucleus size is maintained. And this is what we see normally in pterygiums. This hyperplasia can get reverted back if we take out this external stimulus. But sometimes what happens when the stimulus continues, it gets the normal epithelium converts to squamous metaplasia. What do you mean by squamous metaplasia? Conversion of one type of epithelium to another type. Here, the non-stratified epithelium becomes stratified epithelium. Okay, so this squamous metaplasia is notorious to get converted to dysplastic cells, especially when you have host-related factors. Maybe it might be hereditary or genetic factors, along with the environmental factors. Okay, they can get converted to ATP and dysplasia, and that's when we call them as OSSN. All right. So that was just about the theory. I'm just going to be showing you in some of our slides where we saw all this in practical. Okay. So this is one of the patient where we saw this pterygium sample. You can see this here. The epithelium size is almost the same. Very few less keratin, almost no keratin here. This is the normal thing. As it progresses, you can see the epithelium thickness is increasing, right? And also this pinkish area is the keratin. That means it's getting converted from one type of epithelium to the other. That is from normal to metaplasia. Similarly, there's another case of OSSN where you can see normal epithelium. Again here metaplastic epithelium, and as you see here, these are the dysplastic cells what you see here, right? So we have all the three types of epithelium here. That means to say maybe if we had left this pterygium for a longer time, from squamous metaplasia it would have got converted to maybe dysplasia, indicating that pterygiums can get converted to OSSN, right? And we did a study in our hospital where we took around 1 year sample of the pterygium and did a histopathological examination. So as you can see here, we saw three variants in it. One is the normal or hyperplastic epithelium, which is normal and it is expected. That was in almost around 40% of the patients. You can see this here. The epithelium is still normal, right? And the second type was around 60% of them did show squamous metaplasia. This was surprising to us. This should not have been there, right? If it was just a benign lesion, as it was explained earlier. And the other type, what we saw was OSSN. I mean, this was subclinical OSSN, maybe. I mean, maybe some of it which was best clinically, right? And also, when we checked the OSSN samples for the past year, we saw that almost 65% of them had underlying pterygium, means they had developed from a pterygium to a OSSN. And how did we prove it? By showing this elastotic degeneration in the stroma, which is there in almost 100% of the pterygium and almost 98% of the OSSN samples, right? And why do we have these changes in the epithelium? What molecular changes does happen? So we all have been hearing about this P53, right? Any mutation in this P53 can lead to precancerous or malignant lesions. This P53 protein is responsible for arresting the cell cycle. That means it doesn't allow for the cells to divide uncontrollably. And when it divides uncontrollably due to a mutation in the protein, it can lead to premalignant and malignant lesions. So in our sample, all those pterygium with the squamous metaplasia and OSSN showed overexpression of mutated TP53, indicating that these are premalignant or malignant lesions. Whereas without squamous metaplasia pterygium samples did not show any expression of this TP53. Okay. So these are some case examples. This is one of our 11-year-old patient who presented with left eye nodule. When we saw in the other eye, you can see this here. This is an early wing-shaped lesion. I mean, that is a early pterygium with pigmentation. The left eye had a classical OSSN, RB stain positive, keratinized areas, and all these vessels. I mean, what you can see the also. And when we looked at the patient, he had freckles. Freckles in Indians is not common, right? Whenever you have freckles, you just need to rule out maybe something like xeroderma pigmentosa. This patient was a known case of xeroderma, I mean subclinical case. So they are known to have pterygiums as well as OSSNs. And they have mutations in the genes also. So all these are associated. Another patient, 36-year-old female, classical OSSN again in one eye. The other eye you can see there's a pterygium. What is interesting is other eye shows this pigmented lesion. This can be a primary acquired melanosis, which is premalignant lesion. That means this has premalignant lesion also. And here also you can see this underlying pterygium, indicating that maybe there was a pterygium which got converted to OSSN, right? So coming back to our question which we started off. So does pterygium stop or does it convert? Yes, definitely it can get converted, especially in the presence of mutated P53, where it makes the normal epithelium to change to squamous metaplasia and maybe to dysplasia. This is the link that maybe we are overlooking. And also, when we meet premalignant lesion in any part of the body, what it denotes is it invades normal tissues, it has recurrences even after surgery, and it coexists with secondary premalignant lesions. So does pterygium have all this? Yeah, definitely. It does. Pterygium, we know, is a degeneration condition of the conjunctiva. It does invade cornea, right? And after surgery, it can, the recurrence rate, depending on the technique of surgery, it can be as high as 60% to 5%, as low as 5%. And it does exist with dysplasias and PAM, as shown earlier. So what was interesting to note was, this was a article, I mean, from WHO, which was published in 2023 March. So they classified this tumors of eye and orbit again. I mean, there's a new classification where they've included this pterygium and pingicula under tumor-like lesions now. That means further substantiating that, yeah, these are not just benign lesions, they are tumor-like lesions or maybe premalignant. Okay, so take-home message for today. So pterygium with squamous metaplasia has premalignant potential, and maybe it is time to be considered as one of the spectrum of OSSN. And all pterygium sample needs to be sent for histopathology, and this is what WHO now recommends, to look for any squamous metaplasia or something. And when this squamous metaplasia is there, and if IHC shows overexpression of P53, these patients need long-term follow-up, and always treat them like a patient how you treat them with xeroderma pigmentosa. Tell them to wear caps, use sunglasses, and all those. This is quite important. Thank you.
Thank you very much, Dr. Harsha. That was a very enlightening thing. Thanks. That is classifying pterygium along the malignant lesions, and along with the regular ophthalmologists, we have got other moderators here. We have got an ocular pathologist and a pathologist madam who are sitting there. Can you just guide us whenever we see a case of pterygium or a pingicula clinically, how to go about before we operate? Should we send the case to you for an impression cytology? We would like inputs from you, please.
Good morning, everybody. At the first outset, I would really like to thank TOS. It has a very vibrant scientific committee and a very unique concept, novel concept of introducing other field also into your spectrum of healthcare, and especially pathologists who we are like the unsung heroes of healthcare system. So thank you for giving us the opportunity. That's one thing. Second thing is coming to this topic, OSSN in pterygium is a beautiful workup, which the take-home point is every single thing, it has to be taken into account, send it for histopathology. Yes, over here in my practice, past 10 years, we have a couple of ophthalmic ophthalmologists over here. They do take out lesions, but only the practice is like which looks atypical, something which appears very reddish, where there is a papillomatous growth, where it looks little plaque-like nodule. These are the things which are usually coming. But now the dictum is anything which you see on the cornea, around and in and around, if it looks any sort of growth, please take it and send it for histopathology. The only point I would like to stress over here is, which has not been explored much but has a lot of potential, is cytological diagnosis, which is even more easier and quicker for the ophthalmologist to know whether it is a lesion or not. For example, a simple nitrocellulose paper can be used to, or a cyto brush can be just applied on the lesion, and then we can see the cells. The cells will definitely show the dysmorphic features, and we can tell it is an atypical lesion. Because histopathology, all of us know, even if it is a smaller lesion, it takes, once you submit a tissue for histopathology, it takes nearly about 3 to 4 days is the minimum turnaround rate for it to get processing and for you to get the result. Even more quicker results, easier results, less financial burden is something, cytobrush and cytotechnics, which I have been using throughout, because we are practicing in a tier 2 city. Here mainly our problem is the patients are not so affordable to go even pay for their histopathological diagnosis. So what we do is, which I practice, is simple cytotechnics. That is one thing which I wanted to highlight. Second thing is, apart from the even more apart from cytological diagnosis, the stains, simple methylene blue, rose Bengal stains, these can also stain these, as you said, these cells have been affected, so they are dysplastic cells, so they absorb these stains very quickly, and we can observe dysplastic cells through all these dead and devitalized tissues. Will take up methylene blue, rose Bengal stain, and that's another easier way to identify these cells, and we can give quicker reports, and the ophthalmologist can decide how best to go about it in the treatment thing. The third thing I want to tell you is CIN, any squamous cell anywhere, it can undergo, if there is a point of irritation, chronic irritation, it can undergo a metaplastic change and it can become a CIN. But do we need to be really worried about it when you, for the patient wise, whether CIN 1 or 2 or 3, whether it is invasive, even if it is in the milder grade, the progress of the lesion to become squamous carcinoma, it takes a very long time. It takes more than 10 years. So do we need to diagnose it? Is it so important for us to tell whether it is CIN or 2 or 3? Yes, definitely. It matters a lot, because the treatment part of it is decided lots about the grading of this squamous cell lesion. So it becomes very important, whatever lesion is there, to excise it or use simpler invasive techniques. Kindly ask for it in your lab that you want this test, and definitely it can be done. Thank you.
So good morning everyone. So like madam said, and like what sir was asking was, does impression cytology have a role in differentiating pterygium and OSSN? Definitely it does, but this comes with a pinch of salt. What happens here is, the impression cytology paper, we are just placing it on the surface. So when there is a mild dysplasia, there is involvement of only the lower 1/3. So that those are the lesions which will get missed, because we're just pressing the paper on the surface. So mild dysplasias, they tend to get missed. But where is impression cytology helping is when your RB stain is positive And when you still feel that it is pterygium and there is this small area where you feel it is gelatinous, those areas definitely matters. But again, performing the impression cytology is a challenge. You have to it is non-invasive, but trust me, we do it for almost all the cases where clinically, they have a little doubt. Patient has to be cooperative, and you should hit the paper on the same area of the lesion. So even if you hit the paper on a normal conjunctiva and you send it for processing, we go wrong there. Another thing, what we are doing routinely in NN is we also correlate this with the ASOCT scan. Now, ASOCT, you see abrupt transition. Then in ASOCT, you're seeing hyperreflectivity, and on impression cytology, you're seeing dysplastic cells. Only then, yes, we tell the clinician that yes, there is dysplasia. Go in for an excision with wide margin. So this is one thing. Like Madam highlighted, one important thing what we want to stress is don't discard the tissues. I think histopathology, 400, 500 rupees. I think nowadays most of the crowd is affordable for that. Like in general surgery, we have been seeing since long, even an appendectomy and a gallbladder cholecystemic samples are routinely sent, even DCR samples. So what we are seeing, so the study came up because we started, all the samples started coming to the lab, and that is when we started noticing and we started following up these patients, how they respond. And again, India is in a high UV belt index, and especially southern India, we are seeing these cases are more. So my ophthalmic pathology colleagues in Germany, they tell me that they hardly see cases of OSSN or pterygium. So all these are related. Now, WHO 5th edition itself, WHO, it is the standard tuber classification, and that has brought, so initially when I think my husband was telling that when he studied his books, it just said a degenerative condition, but now they've included it as a tumor. And with progress, with more molecular understanding, we've also seen that yes, they do harbor pre-malignancy, they can get malignant. Okay, and